Good morning. I'd like to thank the organizers of the conference and the wonderful NASM staff for a terrific conference. And I'd also like to thank Dr. Carlin for inviting me to represent the community perspective. I work in a community cancer center that's part of the Penn Medicine system, and I'm also representing the Association of Community Cancer Centers, which I think is relevant because 85% of people in the United States get their cancer care in the community. My slides are not up yet. Okay. Thank you. All right. So it's been said that the future is already here. It's not yet evenly distributed. This map of the crown jewels of our cancer system, the NCI designated cancer centers, certainly tells a story. As does this map, which shows the practices that provide medical oncology across the United States. This comes from ASCO. It represents medical oncology practices, both private practices and those that are associated with community cancer centers. And yesterday we heard from Dr. Alterowitz about the VA system, which he mentioned has 1,200 locations, a third of them rural, and he mentioned that 3.5% of patients in the U.S. get their cancer care through the VA. And this is relevant because there are 4 locations or 4 settings of cancer care in the U.S., which you can read across the top: academic and research institutes, community practice, small private practice, and government. Now, there's some overlap in mission, there's some overlap in staff, but we can read along the first 2 columns. The mission of the academic research institutes, of course, is to relentlessly pursue cure through research, teaching, and patient care. Community sites are focused on population health and patient care. There's lots of overlap, of course, but the services and the people who work in those settings are a little bit different. The workforce, particularly in our academic centers, is people focused on basic and clinical research, as well as people providing clinical care. But in the community, it's mostly oncology clinicians doing care. And again, there's overlap. People do all things in all settings. The highlights, of course, of the academic centers are moving the research agenda forward, and the highlights in the community are being able to provide the continuum of care. And there's some limitations. Distance and capacity bedevil our comprehensive community centers, and depth of specialization and availability of clinical trials are limitations in the community. Many academic centers, of course, provide the care in the communities where they're located as well. So there's lots and lots of overlap. Dr. Isek yesterday reminded us that innovation in technology is what drives progress, and that's certainly the case in oncology. You can see in this arrow the development of oncology over the last 85 years. Much of it happened within our lifetime. The technologies at the top of the arrow, starting with radiation, the development of chemotherapy, infusion pumps, which helped us move chemotherapy out of the academic medical centers, out of the hospital, into the community, into the outpatient setting. Genetics, which certainly increased the precision and the elegance of our treatments, telemedicine, and now AI. And across the bottom, you can see some of the supporting structures and organization that have supported this progress, starting with the founding of the National Cancer Institute in 1937, the National Cancer Act in 1971, development of medical oncology as a specialty across the 70s and into the 80s, the Community Clinical Oncology Program, the CCOPs, which were founded in 1983, the Medicare Modernization Act, the NCI Community Oncology Research Program, the NCORPS, which Dr. Nguyen mentioned to us yesterday in 2011. And now here we are with integrated diagnostics, which I think is really big, and I think is really going to be one of the underpinnings, one of the structures that continues to move our field forward. And yesterday, Dr. Leonard said, what lab is going to do this? What people are going to do this? And I think it's going to be a collection of lab and a collection of people, but I think we're going to need some organization around a shared mission, a shared language, shared resources, shared timelines, whether we're developing a new branch of an existing program or a new institute. I don't know what it is, but I think we're going to need some organization to get us farther and faster. The challenge is that it's estimated that less than 15% of research is translated into practice, and the mean time lag required to translate research into practice is 17 years. Now, I'm not sure that this applies to all aspects of everything we do, but there's some truth in this statement. It takes a long time for dissemination of knowledge. It takes a long time to train practitioners. Translation across organizations is super complex. You all know what it takes to start something new and operationalize in your own location. And I'll add something that we heard yesterday, which is culture, which is really biased against change, resources, and the complexity of getting anything this big done. Dr. Helena Toba Johnson yesterday said, where is this work going to happen? Where in the clinical workforce is this going to land? And this slide actually is an adaptation of something that comes from a National Cancer Policy Forum workshop that Larry Shulman led on the cancer workforce, the cancer care force, which is already stretched with what we're doing today. And this looks at the cancer care force as 4 parts. I'll start with the patients in the middle, which Dr. Davidson mentioned yesterday to us are siloed. Patients in the middle flanked by caregivers on the left, clinicians on the right, and supported by AI, digital solutions, leveraging technology to share and integrate information to improve outcomes, efficiency, and reach. That's a good thing because the cancer care force is not growing. The need is growing. Fortunately, digital solutions and computing power are growing and I think need to be part of the solution. So if we focus on the patients in the center with the idea of improving patient experience and outcomes, we need to be able to profile and communicate individual risk. This was mentioned by Dr. Politi yesterday. It's especially important for preference-sensitive decision-making, shared decision-making. We need to be able, as Dr. Shulman mentioned, to collect and use patient-reported outcomes. And we need to be able to make sure that our patients can negotiate our system and have access to care. It's helpful, I think, to loop in caregivers. They make a tremendous contribution to our care system, and we really need to activate our caregivers by providing education and ability to them, providing access to the electronic medical record. And then our clinicians, our physicians, our advanced practice providers, our nurses. Who hasn't heard about the problems with workload and burnout? We need to do what we can to increase clinician efficiency, effectiveness and resilience. And the challenge of the continuum of oncology care, most patients get their treatment in multiple locations from multiple groups of providers using multiple different tools, whether it's initial diagnosis, active treatment, surveillance, and recovery. I think it's important, we need to think about the importance of communication, bidirectional communication across all of these sites. That includes making sure that who knows who does what, who's responsible for what, making sure that our communication is precise, accurate, and timely. So to activate integrated diagnostics in community settings, I would suggest networks of care must share competence and collaboration across locations. Infrastructure must be built for cancer imaging networks to share expertise. As Dr. Maripol mentioned yesterday, reports to clinicians must be timely, understandable, and usable at both the clinic and the bedside. Integrated diagnostic reports should be seamlessly incorporated into the EMR and should be automatically interfaced with the guidelines that we widely use, such as the NCCN guidelines. And to ensure equity and representation, we all need to do our part, no matter where we are, to build knowledge, to collect and share patient data, to create a data bank similar to the collection and development of a tissue bank. So my recommendations from a community perspective: to be sure that we have equitable access to precision diagnosis and clinical trials that improve outcomes for every cancer patient in every community, are the following three. Recommitment of Congress and the NCI to establish a hub-and-spoke delivery system. We need a cancer care system in this country. A congressional mandate for EHR interoperability. You heard about this from Dr. Osterman yesterday. And to expand the capacity and representativeness of the oncology workforce, including diagnosticians. 3 quick points on this. The capacity can be augmented by digital tools. The representativeness of the cancer care force really means that we need to match our care teams to the people we're caring for, so that people are representative and including diagnosticians. As Dr. Gold mentioned yesterday, we really need to train a generation of caregivers in a different way to integrate these electronic tools. So I thank you for your time.